And our speaker is Miss Mary Young. She is a pharmacist. She comes to us from UNM. She is a clinical oncology pharmacist, and her primary focus is on solid tumors. Her favorite things to do are do therapeutic recommendations as far as for the clinical team. She loves to do patient education and supportive care. But her fun fact is she spent a whole month in Greece last year, a whole month. And so I asked her specifically, is it worth all the hype? And she said, some places are and some places are not. So if you're planning a trip to Greece, she will be a great travel agent for you.
So thank you all for having me here today. I'm so excited to speak to you all. I work very closely with several nurse practitioners day in and day out. Can I get a show of hands? Anyone who works in primary care? Wow, majority, awesome. Anyone in oncology, hematology, anything? No? Oh, a couple people, that's exciting. Okay, awesome. Well, I will try to cater this to the PCPs out there. But as you know, oncology can get overwhelming. So I will try to break it down as simply as I can. I have no relevant disclosures, unfortunately, but am interested. That's a joke. My objectives today are to describe the latest advancements in cancer treatment. Secondly, to identify any potential toxicities from those new therapeutic options. And lastly, learn how to develop recommendations for the management of drug interactions. As we all know, oncology is a very fast-paced growing field. The chart on the left shows the new oncology drug approvals from 2018 until now. As we can see, there are over 60 different new drugs since 2018. And we are the fastest growing field as far as new drug options. On the right, we have new indications. We always get new indications in oncology. The month that I went to Greece and came back, my primary focus is genitourinary cancers, and the guidelines just changed completely. When I got back from work, I didn't know how to do my job anymore. I was like, I gotta go read the guidelines, be right back. So brief overview of what I'll discuss today is immunotherapy, Hedgehog pathway inhibitors. Then I will segue into breast therapeutic options, Pi3k inhibitors, Parp inhibitors, capecitabine, the new antibody drug conjugates, and Cdk46 inhibitors. Those are not limited to breast, but this was the only way that I could lump them all together to make sense. And then Pdhfr inhibitors, TKIs, and then genitourinary specific agents. I'm sure that a lot of you in here have heard a lot about immunotherapy and have a lot of patients that are on immunotherapy. But the way immunotherapy works is that it blocks this PD-L1, PD-1 interaction and allows the T cell to target the tumor cell and actually kills the tumor cell. So in a way, it is basically revving up your immune system. And some popular immunotherapy options you'll see patients are on are pembrolizumab or Keytruda, and nivolumab or Opdivo. Another common one is ipilimumab, and that's Yervoy. There are several indications you can use immunotherapy in. I won't read them all to you, but the newest indication is in esophageal cancers. The side effects, basically, it's revving up your immune system. It can cause inflammation in all your different organ system. Any organ system you can think of, it's gonna cause some kind of inflammation. So some examples are on the right. It can cause pneumonitis, it can cause myositis, colitis, really anything you can think of. And then as far as drug interactions, since immunotherapy revs up your immune system, you don't want to give patients steroids chronically, prednisone 10 milligrams or equivalent for a long time, because you're basically counteracting the effects of immunotherapy. And then potentially PPIs. There have been several studies that shown that PPIs can possibly decrease the effect of immunotherapy, but they have been mixed results so far. And then as far as monitoring, since it can cause hepatitis, we monitor LFTs. It can cause nephritis, so we monitor patients' serum creatinine every time they come in. Immunotherapy is usually given IV, and it's usually every 2, 3, or 4 weeks. And that's when we start patients off at that frequent dosing. And then after they've received a couple of cycles and they're not having any side effects, they aren't progressing on it, we usually increase that dose to twice as much. So if they're on every 2-week dosing, it's going to be every 4 weeks and so on. It can also cause thyroiditis. So again, we monitor thyroid function. A lot of these patients will end up going on synthroid replacement. Sometimes we refer them to our endocrinologist on site, and then can cause hyperglycemia as well. So since the majority of these patients do experience side effects from immunotherapy, there is a specific NCCN guideline for immunotherapy related adverse effects. I'll refer to those as IRAEs. If you don't have an NCCN account and you do manage cancer patients, I would recommend to sign up for a free NCCN account. It's very helpful. And this whole guideline will spell out how to manage each one of those side effects. So if they have hepatitis, it spells out specifically what to do. If they have grade 1, this is what you do. And then as far as the grading, there's something called the CTCAE for grading. That stands for Cancer Therapy, Common Terminology Criteria for Adverse Events. So you would refer to that and then use that in tandem with the NCCN guidelines. But basically the image on your left, you'll see as the timeline if they were only on one immunotherapy agent, and then the one on the right is if they're on dual immunotherapy. So you'll see the picture in the middle, if they're on dual immunotherapy, all the side effects tend to happen earlier and they get pushed up earlier. But the table on the right will show you just in general how we manage these side effects. If they're grade 1, you'll just continue therapy with close monitoring with exceptions of any neurologic toxicities, hematologic and cardiac toxicities. If they're grade 2, then we hold therapy in general, and then we give them prednisone, and it's a high dose prednisone. So anywhere from really for grade 2 is 0.5 to 1, but for grade 3, we can go up to prednisone 2 mg per kg per day. And we'll continue this for a couple of weeks and watch if they're responding to this. And then grade 4 is generally permanent discontinuation. But going back to the picture on the left, you'll see skin toxicities at about 4 weeks. And this is usually a maculopapular rash or pruritus or dermatitis. Rarely patients can experience SJS or TENS. There we just recommend PO antihistamines, topical steroids, sometimes a derm consult where they can biopsy and actually diagnose that patients are experiencing skin toxicities. Next, you'll see diarrhea colitis. That's usually about a month into treatment. We'll recommend Imodium, Lamodal, hydration, sometimes C. diff testing, and we'll go into more diarrhea counseling points later on in this presentation. And you'll see endocrinopathies next at about 7 weeks. Patients who already have primary or secondary adrenal insufficiency, most patients will stay on the steroids long-term at a low dose. And then for thyroid disorders, I already mentioned most patients go on levothyroxine, but we monitor, especially at UNM, we monitor them about every 2 to 3 cycles of immunotherapy, especially if they're getting every 2 or 3 week dosing. And we watch the TSH, and usually whenever it goes above 10 is when we'll start starting them on thyroid replacement. But anything below that, we're not very worried about that. And then if patients have things such as pneumonitis, we'll get a CT chest to see if that's actually going on. We'll give them steroids, we'll get a sputum culture, things like that. Next is, I'll talk about anti-LAG3. So this works in combination with PD-L1 inhibitors. It's just another receptor on the T cell and the tumor cell. This is brand new. We will actually have a patient starting it next week. Our very first patient. This study just came out recently, but I would imagine that anti-LAG3 agents are going to get very popular in the next 5 years or so. So you'll see them commonly with immunotherapy, but it just helps get better outcomes and works in synergy with the PD-L1 inhibitors. So the only approved one right now is relatlimab and nivolumab. The brand name is Opdualag, and it is indicated in melanoma. So they have similar side effects as far as immunotherapy. And so same thing again here, you want to avoid chronic high dose steroids in these patients, and then monitor the same thing you would with immunotherapy. And right now they're only, this combination is only provided together. So it's a packaged drug. You can't just give relatlimab and then like pembrolizumab. And then the only side effects that is more common is arthralgia with the anti-LAG3 agents. And they are studying in multiple disease states. Next, I'll move on to Hedgehog pathway inhibitors. This was requested that I speak on this. So it's a little bit older. It's not new within the past 5 years or so, but maybe 8 years or so. So Hedgehog pathway inhibitors are small molecule inhibitors. So it works on the smoothen gene, and it targets the Hedgehog pathway, which is a known driver of basal cell carcinomas. So the two examples are bismodegib and sunitigib. It's only used in basal cell carcinoma, so not your melanomas or other cancers. Some side effects are muscle spasms, fatigue, taste changes, alopecia. And as far as drug interactions, definitely pH altering agents such as PPIs, H2RAs, and antacids. And the interaction is that they can all alter the solubility of these Hedgehog pathway inhibitors. These are all oral chemotherapy agents, by the way. So it reduces their bioavailability, decreasing their efficacy, which we don't want in cancer, obviously. And sunitigib is a major 3A4 substrate. And on the next slide, I'll have a list of drug interactions just as a refresher, but I'm sure you're all aware of those. As far as monitoring, the big one here is pregnancy tests. So it can cause embryo fetal toxicity, is a black box warning. So therefore they recommend, even as far as no donations of blood products or semen during treatment, and for at least 7 months after the last dose. A lot of these agents you'll see have a really long half-life. So that's why the 7-month recommendation comes in. As far as drug interactions, I'll just talk about CYP3A4 since most of these drugs are work on CYP3A4. So as a refresher, inhibitors on your left and inducers on your right. So with inhibitors, it can increase the concentration of any CYP3A4 substrate. The big ones are your azoles, Itra, Vori, and Poza. And then moderate CYP3A4 inhibitors are your calcium channel blockers, fluconazole, grapefruit juice is very common. And then inducers they can decrease the concentration of CYP3A4 substrates. And common ones are apalutamide, enzalutamide, phenobarb, carbamazepine, etc. And then you have your moderate inducers, which are St. John's wort. I'll move on to breast cancer agents. Again, these aren't just used in breast. So your Pi3k inhibitors also work on CLL and follicular lymphomas. Your Parp inhibitors also work on ovarian, prostate, breast, pancreatic, etc. And then capecitabine is not a brand new one, and I'm sure that you guys have heard of it, but I do want to talk about a new reversal agent for capecitabine. So it works on breast, GI, ovarian, pancreatic, head and neck, etc. And then the antibody drug conjugates work on several different cancers. And then lastly, the Cdk46 inhibitors. So the Pi3k inhibitors are small molecule inhibitors of Pi3k, which is just a kinase. And by inhibiting this, it results in apoptosis of malignant tumor cells. And then on the right, you'll see the different isoforms of Pi3k. So you have your delta, gamma, beta, alpha, and alpelisib, which I'll go into on the next slide, specifically targets that alpha isoform. So we'll mainly talk about Piqray or alpelisib today. And that's usually given in combination with fulvestrant in breast cancer for Pi3k metastatic HR positive, HER2 negative breast cancers. But then you have all your other Pi3k inhibitors, which also work on chronic lymphocytic leukemias and then follicular lymphomas as well. The main side effects of Pi3k inhibitors, if you have any patients that come into clinic that are on alpelisib, again, these are all oral agents, so you can commonly see these patients in clinic, and they'll be on it for months until they progress or don't tolerate it anymore. So the main one is hyperglycemia, and then I'll go into that on the next slide on how to manage hyperglycemia on these patients. And some other side effects are rash, GI, hypersensitivity, pneumonitis, and increased serum creatinine. I'll go into detail more about GI side effects on the next slide as well. This one is a minor CYP3A4 substrate, so not a major one like most of our other agents here. We want to monitor their fasting blood glucose and A1C, especially at baseline, and then every 3 months at least. And for the clinical pearls, patients should take this with food, and then if they happen to miss a dose, they can take it within 9 hours of their regularly timed dose. Otherwise, just skip the dose, and I always tell patients never to take 2 doses at once, which should be common sense, but as we all know, lots of things are not common sense to patients. And then again, embryo fetal toxicity. So you want to counsel patients to use effective contraception. This applies to men and women during therapy, but continue that for at least 1 week after the last dose because it'll stay in their system. Okay, as far as toxicity management, for hyperglycemia, this was studied in the SOLAR-1 trial, and they only included patients with a A1C of 6.4 or less and fasting blood glucose of 140 or less. So they definitely selected out any patients with diabetes. And it was reported in that study that 64% of patients experienced hyperglycemia, and a third of those patients experienced grade 3 hyperglycemia, which is a blood glucose of over 250 to 500. And this was more pronounced in patients who were diabetic or pre-diabetic. And if hyperglycemia does develop, we'll start metformin, which is standard practice, and then we'll consider dose interruptions and dose reductions if needed. And then upon discontinuation of alpelisib, patients do return to their baseline for the most part. And for patients, you can recommend that they consult dietitian with any dietary modification changes, lifestyle modifications, things like that, and then consult endocrine if you're having a hard time managing their hyperglycemia. But definitely refer to the package insert. They have very specific guidances on if their glucose or A1C is this is what you do. And then if that doesn't help, this is the next step. And then diarrhea was the second most common side effect. About 60% of patients experienced this on trial. 6.7% was grade 3, which is an increase of 7 bowel movements over their baseline. So quite a lot of diarrhea. And again, there are specific guidances on how to manage diarrhea in the package insert. And it's also very important to counsel patients on lifestyle modifications if they are experiencing diarrhea, like stopping lactose-containing foods, laxatives, bulk fiber, things like that. Encourage the brat diet. Here you also want to counsel patients to stop high osmolar food supplements, such as Ensure Plus or Jevity Plus, the ones with fiber. And what I do often is counsel patients how to take Imodium. As I'm sure most of you know, that the directions on the box are a little bit different than how we counsel patients on Imodium, and I'm sure in primary care as well. But I do counsel them that they can take a max of 16 milligrams a day, which is twice as much as the over-the-counter box. Next is dermatologic side effects. And as you can see, quite a few patients experience this. 9.9% experience a grade 3 dermatologic side effects, which means that it covers over a third of their BSA. I don't know if you guys are familiar with the rule of nines, or do you know like how much is 30% of a BSA? No, okay, yeah, okay, awesome. If you don't, you can ask them. I'm just kidding, you can ask me afterwards. But as far as dermatologic side effects, the most common was rash, and the image on the top right are images of macular-papular rashes, and then at the bottom you'll see pictures of DRESS syndrome, which is extremely rare, but it can happen and it is life-threatening. But again, very rare. But if you see a patient with rash in the clinic and they are on alpelisib, you can definitely make that connection and know how to manage it or refer them back to their oncologist if that's an option. Next, I'll move on to Parp inhibitors. So these are fairly new and definitely all the rage right now. So as far as how they work, they help repair any DNA damage. Some examples are olaparib is the most common one, but with inhibiting Parp, it leads to more DNA damage, which leads to a double-stranded DNA break. And therefore, normal cells can repair and divide, and then cancer cells can't survive because of this Parp inhibition. So the most common ones is olaparib or Lynparza in prostate. Prostate is the newest indication for Parp inhibitors, and there we can also use rucaparib or Rubraca. For side effects, the biggest side effect here is myelosuppression. So your patients are at an increased risk of infections because all of their cell lines are being depleted. As far as drug interactions, there are quite a few and they are drug specific. So I would just recommend to consult your pharmacist. And so because of the myelosuppression, you want to monitor their CBCs commonly. And it can be so severe that it can cause AML and MDS, which I've seen a handful of times, but it is pretty rare. So with niraparib, we'll monitor CBC with DIF weekly for the first month and then monthly thereafter. And then all others is baseline and monthly after that. It does have a renal dose adjustment, so we do monitor their serum creatinine. And then depending on the indication, sometimes they have to have a BRCA mutation or an HRD status, and it is very emetogenic. These are all orals, so we want to prescribe patients antiemetics. And I will say that not all providers are great at doing this. So if you see a patient on a Parp inhibitor without antiemetic, maybe reach out or provide them an antiemetic if they need one. And then if their blood counts don't recover to less than a grade 1 after 4 weeks, if they are having a lot of myelosuppression, then further evaluation is needed. We usually send them to our hematologist. They'll get bone marrow biopsies generally. Next is Zeloda. This is the only traditional chemotherapy we'll talk about today, but it's a pyrimidine antimetabolite. It inhibits thymidylate synthase. So it blocks methylation and interferes with DNA. It's specific for the G1 and S phase of the cell cycle. So it inhibits replication in the G1 and S phase, as you can see down below. Zeloda is a brand name for capecitabine, and then 5-FU is what it converts to, and that's the IV form. And we use both. So the newest indication is for breast cancer, and we do have numerous patients on this now, long-term, but it can also be used in GI, ovarian, pancreatic, head and neck, and so on. The big side effect with Zeloda is diarrhea and hand-foot syndrome, but it can also cause hepatotoxicity and myelosuppression. As far as drug interactions, I always stop patients if they are on PPIs, and we'll try to stop them as soon as we know that we're prescribing Zeloda, since PPIs stay in your body a while. So we'll make sure basically that there's some time for it to get rid of in your body, basically. Since it does take us a while to get oral chemotherapy approved, it usually takes a minimum of 2 weeks or so, but can definitely take a lot longer as far as that turnaround time. So it's usually enough time for the PPIs to stop working in your body. But we stop this because it can diminish the therapeutic effects of Zeloda. And then antacids could increase the serum concentration of Zeloda. So we recommend patients to not be on antacids or PPIs. And then as far as folic acid, it works on the same pathway as this agent. So it can enhance the side effects of any 5-FU products, which is 5-fluorouracil. So we definitely want to tell patients to stop taking folic acid if they're on that. And then if patients are on warfarin or any other vitamin K antagonist, we just tell them that Zeloda can increase the serum concentration of warfarin, and definitely let their Coumadin clinic clinicians know. And then for this in clinical pearls, this is an oral agent. It's a prodrug of 5-FU, which is the IV form. Obviously, the PO form is going to be a lot easier for a lot of patients to take at home. We have a lot of patients that come from hours and hours away that don't live in Albuquerque. So this is very convenient for a lot of patients if they are able to understand how to take an oral drug and how to manage side effects. It does undergo hydrolysis in the liver, as you can see the picture on the top right. And then from there in the tissues, it forms 5-FU and works on the tumor. And like I mentioned, the big side effect of Zeloda is hand-foot syndrome. And I believe later on you guys have someone talking about neuropathy, so that's awesome. That's very exciting. And as far as hand-foot syndrome, it usually begins 2 to 12 days after therapy. It can present in several different forms, so redness, swelling, pain, dryness, itching, cracking, flaking of their skin. It can even progress to blistering and ulcering and skin sloughing. As far as management, this isn't specific for Zeloda, but I did want to touch briefly on management of hand-foot syndrome. In general, avoid friction or trauma on your hands and feet. Moisturize. They can use any over-the-counter alcohol-free emollient is what I would recommend. There's also urea or udder cream patients can buy, which works really well. And then lastly, sometimes providers will prescribe vitamin B6 Pyridoxine, which can prevent or reduce the incidence or severity of hand-foot syndrome. And then there is now a reversal agent for Zelota Toxicities. The need for this is because some patients don't have an enzyme called DPD, which breaks down Zeloda and 5-FU. It's very rare. It's about 1% of patients have this enzyme deficiency, so they can't metabolize the drug. So usually how it presents is we'll have a patient start Zeloda or one cycle of 5-FU, and they have all of these awful toxicities. They call in, they come to clinic, they look awful. We'll send them to the ER inpatient. And then usually we don't test for DPD beforehand. Since it's so rare, it doesn't determine our treatment option. They'll still get this agent. And then in the rare, unfortunate 1% that do have it, who are not metabolizing, we could give uridine triacetate. This is an oral agent, but only given inpatient because it's extremely expensive. It's about $5,000 a dose, and they have to give 20 doses. So 100 grand right there to reverse this agent. And you have to give it within a certain time frame. I believe it's 96 hours within the dose time. So if you have any patients that are experiencing severe toxicities from Zeloda or 5-FU, definitely get them admitted right away. Next, I will talk about antibody drug conjugates. These are fairly new. And the way it works is that you have your antibody, which is in pink, and then your payload, which is your anti-tumor agent in red. They're linked together on one drug, basically. And so the monoclonal antibody will help it attach inside, and then it gets endocytosed inside, and then there's no more need for the antibody. And then you have your payload, which gets in there and is degraded and released, and there basically it becomes active and it causes cell death that way. So it's very specific, and it works better than if you were just going to give the payload by itself. These are a few of the newest antibody drug conjugates. So there are several. The payloads are always different. They can be like microtubule inhibitors. They can be your traditional topoisomerase inhibitors, but it's just linked to an antibody so it can get directly to where it needs to be. So the ones I've boxed in black are what we'll talk about today. So first are the anti-HER2 antibody drug conjugates. The two examples here are Enhertu and Kadcyla. So Enhertu is famtrastuzumab deruxtecan, and then you have your Kadcyla, which is adotrastuzumab and tansine. So the trastuzumab, the monoclonal part is the same for both of them, but the payload is different. That's the deruxtecan and the emtansine, which work in different mechanisms, but both are IV. So as far as the deruxtecan, that is a topoisomerase inhibitor like your irinotecan. So think of Diarrhea for that one. And then for Kadcyla, that one is, you also refer to that payload emtansine as DM1 or TDM1. And those are like your taxanes, your vincas. It's a microtubule inhibitor. A lot of them are used in breast cancer, but now we're also using them in gastric. The newest indication is for lung cancer, but I haven't seen that used in clinical practice yet. But again, it is fairly new. And then also in colorectal cancer. The side effects of these agents are myelosuppression, hepatotoxicity, cardiomyopathy, interstitial lung disease, diarrhea, and infusion reactions. And for Enhertu, you'll see hemorrhage and more neuropathy and more thrombocytopenia. And as far as Kadcyla, you'll see more neutropenia in that one. For nausea, Enhertu causes more nausea than Kadcyla. Again, these are IV agents. We do monitor patients' CBC with diff, their ejection fraction, and LFTs. And then as far as clinical pearls, so there was a study in 2015 in an Asian population, and they did find a higher incidence of thrombocytopenia in those patients. The products are not interchangeable, even though the names look familiar. They both have trastuzumab. They are not interchangeable. The trastuzumab part causes a lot of cardiotoxicity. Here, it's a type 2 cardiotoxicity, which is myocardial dysfunction. It's different than your type 1 myocardial damage, like anthracyclines, which are the traditional cardiac toxicities we think of. So the difference here is that it's reversible. It's okay to re-challenge patients, and usually it's not dose related. Moving on to CDK46 inhibitors. These are our three main agents that we currently use. And the way they work is they're reversible small molecule inhibitors, which select for CDK4 and 6. And these CDKs have a role in regulating progression through the cell cycle, specifically at the G1 and S phase, basically causing arrest at the G1. So here you have abemaciclib. They all end in cyclibs, but just because it ends with that doesn't mean it's a CDK4/6 inhibitor. These are only used currently in HER2-negative breast cancer. And the side effects here are pulmonary toxicity, infection, or increased serum creatinine, with the exception of palbociclib with the serum creatinine. I put the toxicities below. You can commonly see more stomatitis in palbociclib than the others. You can also see fatigue, diarrhea, bone marrow suppression in the order of listed. As far as diarrhea, it does commonly occur usually after the first cycle. The median onset of diarrhea for abemaciclib is at 8 days, and the It is the most common side effect, but in the trial that it was studied in, there were no treatment discontinuations due to diarrhea. And for clinical pearls, there is a pedic dose adjustment. So that's why we're looking at patients' LFTs. Ribociclib is notorious for causing QTc prolongation. So we do get a baseline EKG in these patients. And if they're symptomatic, or if their electrolytes are off, or if they have any, if they're on other agents that are QTc prolonging, then we do monitor them more often. But obviously replete their electrolytes as needed. And palbociclib is the only one out of these that you have to take with food, which can be hard for some patients. And abemaciclib does have continuous daily dosing, and all the other ones are 21 days on and 7 days off. We'll move on to the VEGF inhibitors. VEGF inhibitors work on quite a few disease states, not limited to breast. So basically VEGF inhibitors the most simple way I can explain it is that it works on our vasculature. So it stands for vascular endothelial growth factor receptor. It stops proliferation and formation of any new blood vessels, which basically stops like nutrients and all of that feeding to our tumor cells. And because of the mechanism, it causes lots of side effects like listed here. So hypertension is a huge one, and then proteinuria is the second most common side effect. So they do end with MAB. So you might think of monoclonal antibodies. So the most common one we use is bevacizumab or Avastin. The biosimilar is Mvasi, and then there's several other biosimilars coming up for bevacizumab. But the indication is colorectal, liver cancer, breast cancer, lung cancer, or your glioblastoma, brain cancers. So the side effects, because of how it works, it causes hypertension. It can also cause GI perforation or wound impairment, like healing impairment. So these patients should stop treatment if they are going to undergo any kind of surgery, or if they have a major wound that's not healing, we do stop the bevacizumab. And it lasts a while in your body, so we'll stop it several weeks beforehand. As far as GI perf, most cases occur within 50 days of the first dose. Pretty rare, but it does happen. And then for proteinuria, the median onset was 5.6 months. And then median time to resolution was about 6 months. Again, it lasts a really long time in your body. When patients come to clinic, we always monitor their blood pressure. We also do a urine dipstick. And then if it's 2+, sometimes we'll get UA and then sometimes look at their creatinine to protein urine ratio. And for surgery, you want to hold at least a month before and after surgery. That's at the absolute minimum. Obviously, if they're having emergent surgery, we can't help that. And then sometimes we do the 24-hour urines, but those are a pain in the butt, so we try to avoid doing that for patients. I will move on to tyrosine kinase inhibitors now, or TKIs. These are also used in several different disease states, but I will present the new updates on CML targeted or CML TKI agents, GI stromal tumors, which is just the TKIs used in there, and the TKIs used in lung cancer. TKIs, basically, they work on multiple different receptors. Therefore, they affect different signaling pathways, but ultimately, the end result is that they stop either angiogenesis or cell proliferation. So the different TKIs it's showing up in there. The picture are EGFR, VEGF, which we just talked about, Pdhfr, which we will talk about, and then the BCR-ABL agents are next. And these are just showing the different targets of each agent. These are not all inclusive of all TKIs. These are mainly the TKIs we use in genitourinary cancers, but also used in other cancers. But as you can see, they work on multiple different targets, therefore multiple different side effects. And as far as side effects, it depends on the target, obviously. And then, so we just talked about VEGF. So as expected, hypertension, proteinuria, wound healing complications, things such as that. So our first set of TKIs work on BCR-ABL, and these are for your chronic myeloid leukemia patients. So normally BCR-ABL allows phosphorylation and therefore increasing cell proliferation. So the TKI in the black there, it inhibits the autophosphorylation that's happening in CML. So a common TKI that's been around for quite a while, probably 20 years or so, is Imatinib or Gleevec. I'm sure some of you have heard of that, but not really often used in CML anymore since we have newer agents that are listed. Asciminib is the newest one that just came out this year. It's brand name Scemblix. These cause a lot of myelosuppression. Of course, we're using it for CML. It also causes edema, pleural effusions, diarrhea, rash. And then as far as drug interactions, it is a major 3A4 substrate. There are specific dose reductions with some of these TKIs if patients are on CYP3A4 inhibitors. We don't always have the most accurate med list at the cancer center. We do try to update it as often as we can, but sometimes whenever patients are managed by multiple teams, such as primary care providers, and start them on new medications, we might not be aware of them. I always tell patients to call me if they're starting anything new, but that doesn't always happen, unfortunately. Sometimes I'm able to look at their fill history, so I can be like, okay, I think they started this. Let's talk to them about it, but a lot of patients don't know what they're on, unfortunately. So it's helpful if you see any red flags, any CYP3 and 4 inhibitors or substrates that they're on, maybe let them know to talk to their oncologist. As far as monitoring, definitely there are CBC, LFTs, electrolytes, and then adherence. These agents only work well and only work as they're supposed to if patients follow it strictly. So a lot of this is just daily dosing. You have to remember some of these patients can be really, really young. So this might be the only medication they've ever taken, and therefore they're not going to take it daily. What happens there is you have resistance mechanisms pop up if they're not taking it as they need to be. So if that's the case, unfortunately, the drug stops working. We'll have to switch them to something else. But the more resistant mechanisms that go on, the less effective they're able to work. And then as far as specific TKIs, I put what you have to monitor on each specific TKI. They're a little bit different. Let's see. And then, have I really been talking for 46 minutes already? Sorry, guys, I will speed it up. Next are KIT inhibitors for GIST. Basically, this is the treatment schema for patients with GIST. If they're first line, they're usually on Imatinib, and then as they progress, they'll have to switch to other agents. But the newest ones, which I'll talk about, are Avapritinib and Dasatinib. They specifically target Pdhfr exon 18, and patients with Pdhfr exon 18 usually are not responsive to Imatinib, unfortunately. So this is a really big deal and a big breakthrough for just patients. All of these are oral. We'll talk about Avapritinib and Ripretinib. Those are similar mechanisms. Pdhfr is platelet-derived growth factor receptor. And then Imatinib and Dasatinib we just talked about. And then we'll talk about Regorafenib in lung cancers. So briefly, Pdhfr inhibitors, they work, these drugs bind at two sites of the activation switch and the switch pocket, which is depicted, which inhibits downstream signaling and cancer cell proliferation. The toxicities are CNS toxicities and urothelial toxicities, as with most of these agents, transaminitis and myelosuppression. It is a major 3A4 substrate. And then again, Ripretinib specifically, not Avapritinib, works on VEGF, so you'll have to hold it before and after surgery, a week before and at least 2 weeks after. So we always say at least 2 weeks because we don't know if their wounds have healed from whatever surgery they have. So whichever one is longer, either 2 weeks or until wound healing. And we talked about VEGF, but these are the TKIs, so the oral form. So this is regorafenib or Stivarga. It is used in multiple different settings. Because it works on VEGF, we all know now that it causes hypertension and poor wound healing. And then in Asian patients, we saw a higher incidence of hepatotoxicity and hand-foot syndrome. And this is taken 21 days on, 7 days off. And you want to hold for 2 weeks at least before and after surgery. And here is unique because you have to administer with a low-fat meal, which can be hard for some patients. So specifically, they recommend a low-fat meal as in less than 600 calories and less than 30% fat. So examples they provide are, low-fat cottage cheese, English muffins, things like that for breakfast. So that can be kind of challenging. Next, I will briefly go over the lung cancer agents as fast as I can in the few minutes I have. I apologize. But as you can see, lung cancer has multiple different targets, specifically non-small cell lung cancer. And you can see the breakdown of each of these targets and the incidence we see in the population. Most commonly is EGFR and BRAF, and then you'll see all of the other agents listed. So first we'll talk about BRAF and MEK inhibitors. So they all work on the same way. So you'll see Dubravniv on the right, it inhibits the RAF target, and then you have trametinib, which inhibits the MEK pathway, which is the downstream target. And the reason we inhibit both of these, we use both of these agents, is to overcome any resistance. It was initially studied as monotherapy single agents, but because they were getting so much resistance, they studied it together and it worked a lot better, and patients were able to stay on these agents a lot longer. So these agents are used in melanoma commonly, lung cancer, and thyroid cancers. I see them all used commonly. A big side effect here that's unique is that it can cause non-melanoma skin cancers, which you're like, okay, that sucks. Why are you on an agent that causes skin cancer? But it's controlling the other cancer. And my physician is like, well, at least it doesn't cause melanoma, which I don't know if that's any better. But it causes hyperglycemia, hand-foot syndrome. Febrile drug reactions is a huge one for BRAF/MEK inhibitors, specifically the Dubravniv and trametinib combo. It's not a combo pill, they're two separate pills. And it's hard for patients to take because they have to take, it's twice a day, they have to take it on an empty stomach, and they have to take it 10 to 12 hours apart. So it's very hard if you're like snacking between, get hungry, things like that. One agent is refrigerated, so you can't even take it with you. It's difficult to be on, but unfortunately, these are options right now. And the way that they're packaged, they go together, but not packaged together, is that because they're studied that way because one company makes them, and that's how they're studied. So for the non-melanoma skin cancers, we always tell patients if anything abnormal changes on their skin, let us know. Obviously, we do monitor that when they come into clinic. But moving on to the Dubravniv trametinib, it causes a lot of fevers, and these are extreme fevers, and they're common, and they're known, and they're expected. Pyrexia was seen in over half of patients. The usual onset was 2 to 4 weeks following their start of therapy, and it lasts a median duration of 9 days. So it's not fun, unfortunately. But I usually have 2 different camps of patients. Either they tolerate it really well, not having very many side effects besides initial pyrexia. And then I have patients that don't tolerate it at all, and we have to stop in usually the first month or so, unfortunately. But definitely refer to the package insert if patients are having pyrexia and they're on these agents. I put a snippet below of that table, but if their fever is 100.1 to 100.4, we usually hold until their fever resolves and then resume at either the same or the lower dose. If they're taking both agents, like most patients, we shouldn't change the dose. And if their fever is more than 100.4, or if their fever is complicated by rigors, hypotension, dehydration, or renal failure, we'll want to hold until their fever resolves. And that is quite common. Another pearl is the dream sequence study was just released. I don't think the full publication is out, but just the abstract. But that has completely changed the way we treat melanoma now. Melanoma in the metastatic setting previously was if they have this BRAF target, we didn't know what to do as far as immunotherapy or these BRAF/MEK inhibitors first line. With this dream sequence trial, their conclusion was that they found better results with immunotherapy first in the upfront setting and then targeted therapy in the second line setting. So now we know how to sequence these drugs, which is a big deal in melanoma. I will skip over the MET inhibitor for sake of time. They aren't that common, but if you have any questions, feel free to ask me, and most of the highlights are on the slides. Next, I'll talk about NTRK fusion inhibitors, and they're not that common, about 1% of cancer patients, but they are fairly new as far as indications in other solid tumors, which aren't as common, about 0.5% in other solid tumors, but you'll see them now being moved up first line if patients have this NTRK fusion, and that's in any solid tumor. So this is a new indication. Thank you. I can't see that far, I'm sorry. The side effects are listed below, and the big one for this is that it can cause QTc prolongation, especially when they are on other QTc prolong agents, such as your SSRIs, things like that. And then moving on to the most common target for lung cancer, EGFR inhibitors. These inhibitors bind extracellularly and intracellularly to block the binding of ATP to the receptor domain, and then it shuts off the entire signaling cascade. So really quickly, osimertinib or Tagrisso is the most common one, and it's used in EGFR positive non-small cell lung cancer. And there's new indications for some of the other ones, so pancreatic, non-clear cell renal cell carcinoma, and vulvar squamous cell. And the side effects of this one commonly are diarrhea, rash, xeroderma, and nail disease. So if you have patients on osimertinib or Tagrisso, you'll see a lot of skin changes. You can also see nail changes, and you might not think that that's associated with this drug. If you see a patient in clinic and you're like, what's wrong with your one nail or whatever? It can be one nail, it can be all 10 nails. It's most likely due to Tagrisso. And then it can also cause rash in at least half of patients. We do recommend preventative measures, the common, limiting your sun exposure, wearing SPF, things like that. But also hydration with moisturizers is a good thing for these patients. So it can cause an acne form rash. So it literally just looks like acne, and patients are like, I'm 50, why am I having acne again? It's because of this. So we can recommend initially a topical like clindamycin. Sometimes we'll do PO doxycycline or minocycline. If that doesn't work, sometimes we'll do steroids or just dose adjust or give patients a treatment break. If it gets so bad, sometimes we'll even swab them for cultures. And the big counseling point for this is to tell patients not to use any acne products, such as your over-the-counter acne washes, face creams, things like that, because it can worsen their rash and it's not going to help the acne. I'll skip over the KRAS inhibitors as they're not that common, but I did want you to be aware this is a brand new agent, sotorasib. And Gavreto is also new, and we use these in lung cancer, but again, pretty rare, less than 2%, but it's really commonly used in your thyroid cancer, so your papillary or medullary thyroid cancers. And the two agents here are sulbracatinib or pralsetinib. Again, it does work on the VEGF pathway, so again, causing that wound dehiscence. And QTc prolongation is a huge one here as well. It's dose related, so it's concentration dependent. So if patients are on multiple QTc prolonging agents, we definitely want to monitor and replete their lights. I'm going to skip across the ALK inhibitors and finish with the genitourinary targeted agents briefly, and then hopefully have a minute for questions. This is brand new. They're FGFR inhibitors. Sorry, I keep saying everything is brand new. It's because they are. The main one that we commonly use is erdafitinib or Balversa. The unique thing about Balversa or erdafitinib is that it can cause hyperphosphatemia. So with these patients, definitely want to restrict their phosphate in their diet. So the package insert recommends 600 to 8 milligrams of phosphate a day at the max. And this hyperphosphatemia definitely happens in over 50% of patients. We have unfortunately had to admit several patients because of hyperphosphatemia after starting this. The time of onset is about 20 days. And it also causes ocular toxicity. So sometimes we'll give them prophylaxis for dry eyes. Sassy Tuzumab is a new antibody drug conjugate in this setting. The payload here is SN38, and that's similar to irinotecan. And then lastly is enfortumab vedotin. It's also an antibody drug conjugate. The name is Padcev. This payload here is Nectin-4, and Nectin-4 is located on the surface cells of most bladder cancers. So this is something we don't test patients if they have Nectin-4. We just assume patients have it. So it causes cell cycle arrest and apoptosis in any cells expressing Nectin-4, which is just your bladder cells, bladder cancer cells. And the big one this is hyperglycemia, not as much as your breast agent at the beginning, but it can definitely happen. And we have to hold a patient's glucose is over 250, which commonly happens, unfortunately. And one last slide, anti-androgens. I had a request to talk about that. So here we have bicalutamide and enzalutamide. Apalutamide I'll use in prostate cancer. The big side effect of this, I call it menopause. So lots of diarrhea, hot flashes is the one men complain about. And for that, we would recommend venlafaxine typically, but some other options are gabapentin or medroxyprogesterone or just a treatment break. But this is the overview of what we just went through. And these are some of the highlights which we've talked about. Thank you all for your time today, and thank you for inviting me. Does anyone have any questions if there's time for questions?
I don't know that we have time for questions, but if you do want to stick around, if you have questions, you can meet her in the back lobby.